Bismillahirrahmanirrahim. Today I'm going to talk about another rectal disease problem, proctitis, and then also the benign rectal tumors. The objective of this lecture is that at the end of this lecture, all the students should be able to know what is proctitis, what are the different types of proctitis and their treatment, and then what are the different benign tumors of the rectum. So we'll start with the proctitis. What is proctitis? By definition, proctitis is inflammation of the rectum. Proctitis is often associated with inflammation of colon. That means proctocolitis. So along with the inflammation of the rectum, other parts of the large gut, colon, they are also involved, and sometimes the term proctocolitis is also used. Now, there are different types of proctitis. We can say it may be acute proctitis, chronic proctitis, non-specific proctitis. So this is one way to group proctitis into acute and chronic forms. As far as the etiology of the proctitis is concerned, etiology is unknown. The concept that the condition is a mild and limited form of ulcerative colitis is the most acceptable hypothesis. This is the most acceptable hypothesis, that this is a mild or limited form of ulcerative colitis. Although in this case, actual ulceration is often not present. Now, the clinical features. The patient is usually a middle-aged, and he complains of he's a middle-aged patient, and the complaint is usually passage of slight blood in the stool. He also complains of defecatory frequency. Often the complaint is diarrhea, but it reveals relatively normal action of bowels with some blood, slight blood and then mucus, and then in severe forms there may be pus also in the stools. These patients, they also complain of tenesmus. It's a painful defecation basically with inadequate. The patient says that he wants to pass, but there is urge and he cannot pass. This is tenesmus basically. So there is tenesmus in these cases, along with the passage of flatus and little blood-stained fecal matter. Also, acute proctitis is usually accompanied by malaise and pyrexia. That means acute proctitis is usually associated with constitutional upset also, complaining of myalgias and pyrexia. Now, how we diagnose proctitis? Proctitis, after history, then if we go on to the examination, in that part it is the digital rectal examination. On that, this examination, mucosa feels swollen and is often, there is pain when we are palpating digitally the rectum. Then other methods to diagnose the proctitis, we have to do proctoscopy, we have to do sigmoidoscopy. There are more valuable method of examination and show inflamed mucosa of the rectum. Colonoscopy is also required in these cases. Now, if the diagnosis is confirmed, colonoscopy with multiple biopsies is mandatory to determine the extent of the inflammatory process. So once the diagnosis of proctitis is there, that the rectum is involved, it is inflamed, So it is essential that we should do colonoscopy and we should do multiple biopsies. It is mandatory. So the idea behind is we want to know the extent of the inflammatory process. As I told you, usually rectum proctitis is also associated with inflammation of the rest of the colon also. So that is the reason why we have to do colonoscopy in these patients. Other assessment in these patients to establish or exclude the diagnosis of specific infection, we have to do a bacteriological examination. We can also do culture of the stool, examination of the scrapings or swabs from ulcers, and then we can also do serological tests for the diagnosis in these cases. As far as the treatment is concerned, in many patients, proctitis is a self-limiting disease. But topical use of 5-aminosalicylic acid in the form of Ashfaq, Pentasa, it is used in the form of suppositories or in the form of foam for topical use. Topical steroids, they are also used, but they are less effective alternatives. In very severe form, resistant cases, oral steroids are used for remission. Similarly, we can also use oral 5-aminosalicylic acid in the form of Ashfaq and Pentasa. And oral preparations, they are also available and they are used for the treatment of proctitis. As far as the surgical option in these cases is rarely required. Usually these cases, they are treated medically. Now the next step are what are the different types of proctitis. We can group proctitis into non-specific proctitis and we can group proctitis into specific types of proctitis. So as far as the non-specific proctitis is concerned, this is one form. So this is inflammatory condition affecting the mucosa and to a lesser extent the submucosa, and this is confined to the distal rectum. This is non-specific proctitis. In about 10% of the cases, the condition extends to involve the whole colon, total ulceration involvement of the colon, proctitis, that is of non-specific variety. Now, if we talk about the specific types of proctitis, as we know, it can be a part of ulcerative colitis. Proctitis is present in most cases of the ulcerative colitis, and the degree of rectal involvement may influence the type of operative procedure. So, one specific form of proctitis is that it is part of the ulcerative colitis. About 90% of the cases of ulcerative colitis, rectum is involved. This part is involved in ulcerative colitis, and our diagnosis or biopsy may be confined to the rectum in cases of ulcerative colitis. Then proctitis may be part of the Crohn's disease. Crohn's disease can occasionally affect the rectum, although classically it is spared. Classically it is spared means usually it is not involved in Crohn's disease. Cymidoscopic appearances differ from those in non-specific proctitis. The inflammatory process tends to be patchy rather than confluent, and there may be fissuring, ulceration, or even a cobblestone appearance, which is typical of Crohn's disease. Rectal Crohn's disease is often associated with severe perineal disease characterized by fistulation. Many a time we have talked about the fistula in ano, and then we talked that fistula may be primary, it can be secondary. So the secondary fistula in ano, one of the causes is Crohn's disease. So, rectal Crohn disease is often associated with severe perineal disease, which is characterized by fistulation, fissuring, and hemorrhoids. These conditions are secondary variety in Crohn of underlying cause is Crohn disease. So, coexisting disease is often present in the rest of the colon or small bowel or both. So, which is typical of Crohn disease, and even in rectum, it is the skip lane. It's not the whole bowel which is involved. Another variety, radiation specific types, is radiation proctitis. Radiation therapy is used in the treatment of cervical, prostate, and rectal cancer. It can produce acute radiation proctitis with bleeding, pain, diarrhea, and defecatory frequency. Most symptoms settle within a few weeks, but some patients develop chronic proctitis with symptoms appearing months or even decades after the radiation exposure. So keep in this mind, radiation proctitis can be acute radiation proctitis and it can be a chronic radiation proctitis. Then there is another group of proctitis due to specific infections. These are infections which can also cause proctitis. So there are specific organisms causing proctitis. One is Clostridium difficile. This is an acute form of proctocolitis caused by infection with Clostridium difficile, which can follow after the use of broad spectrum antibiotics. And the notorious one is clindamycin, which can also lead to a membranous type of pseudocolitis. So a pseudomembrane is formed in these patients when this is due to Clostridium difficile. A membrane can sometimes be seen on sigmoidoscopy, and this is pseudomembranous colitis. And I told you that one notorious for this is the antibiotic clindamycin, which leads to pseudomembranous colitis. This you should keep in mind. Another specific infection and proctitis is amoebic dysentery. Amoebic dysentery, the infection is more likely to be chronic with exacerbation after a long period of symptom improvement. Proctoscopy and sigmoidoscopy are not painful in these patients. So, amoebic dysentery, this is another very common type of proctitis prevalent in our society. It is in the form of acute amoebic dysentery. It is also in the form of chronic amoebic dysentery. Procto and sigmoidoscopy are helpful, but they are not painful. We can easily perform in these patients. Scrapings from the ulcers should be sent to laboratory for immediate microscopic examination. Acute amoebic dysentery, in that case, is scraping we see under the microscope. Vegetative form of the amoeba can be seen. Chronicity is marked by spores which are there under when we examine under microscope. Amoebic granuloma. Amoebic dysentery can lead to amoebic granuloma. What is amoebic granuloma? Which is due to amoebiasis, is a soft mass, usually in the rectosigmoid region. Frequently, it is mistaken for a carcinoma. That's why I write down here amoebic granuloma. This is one differential diagnosis for carcinoma because it presents as a mass. Sigmoidoscopy shows ulcerated surface in these patients, but the mass is less friable than a carcinoma. A scraping should be taken in these patients and the material sent for immediate microscopic examination. Their vegetative form amoeba as well as spores can be seen, especially the vegetative form, which is present in the acute form. A biopsy can also be helpful in these patients of amoebic granuloma. Amoebic granuloma of the rectum is encountered in patients who visited a country in which the disease is endemic. So tropical countries, here even on our patient, it's not a very common presentation, but amoebiasis is there in our setup also. Another specific infection of the rectum, tuberculous proctitis. Nearly always this is associated with active pulmonary tuberculosis or tuberculous ulceration of the anus. So tuberculous proctitis, it is always associated with active pulmonary tuberculosis. Some mucous rectal abscesses burst initially, so some mucus in tuberculosis of the rectum, some mucous abscesses they form, they burst, and then they form ulcers. And what is specific about these ulcers? They are having undermined edges. It is a feature of the tuberculous ulcer anywhere, but we are talking here in the rectum. A hypertrophic type of tuberculous proctitis occurs in association with tuberculous peritonitis. A tuberculous proctitis occurs in association with tuberculous peritonitis or tuberculous salpingitis. So keep in mind these conditions, these associations with tuberculous proctitis. Tuberculous proctitis diagnosis requires biopsy. So it is the biopsy which confirms the diagnosis. And obviously then the treatment, once the diagnosis is there, the treatment is anti-tuberculous chemotherapy. Another specific infective proctitis is gonococcal proctitis. It occurs in both sexes as a result of rectal coitus or in female from direct spread from the vulva. In acute stage, the mucous membrane is hyperemic and thick pus is withdrawn on proctoscopy. In early stages, the diagnosis established by bacteriological examination, but later on, it becomes more difficult to recognize. So in early stages, it is easy to diagnose by bacteriological examination, but later on, the diagnosis becomes difficult, and because it becomes difficult to recognize. Gonococcal proctitis is treated by systemic treatment, that means with IV antibiotics, and the gonococcal proctitis responds to these systemic treatment by antibiotics. Another specific type of proctitis, lymphogranuloma venereum. The modes of infection are similar to those of gonococcal proctitis, a sexually transmitted disease, lymphogranuloma venereum. But in the female, chlamydial infection spreading from the cervix uteri via lymphatics to the pararectal lymph node is common. So in these cases, lymphogranuloma venereum causing proctitis, there may be associated lymph nodes in the pararectal area. Proctoscopic findings are the same as in gonococcal proctitis. So the inflammation along with pus is there when the proctoscope is withdrawn. The diagnosis should be suspected when the inguinal lymph nodes are greatly enlarged, although the enlargement may be subsiding by the time proctitis commences. So another point for diagnosis here is that inguinal lymph nodes, they are also enlarged in these cases. So lymphogranuloma venereum proctitis, keep in mind may be associated inguinal lymph nodes, they are also involved and enlarged. So they may be palpable, and this may be helpful in the diagnosis. HIV infection, acquired immune deficiency syndrome, it is also may be associated with proctitis. Patient may present with a particularly fluorotype of proctitis. These patients, they present with fluorotype of proctitis. These are patients of HIV infection. In such patients, unusual organisms such as cytomegalovirus, CMV, herpes simplex virus, and organisms such as cryptosporidium are often found, and they are the cause of proctitis in HIV infection. Another condition of the rectum, that proctitis, strawberry lesion of the rectosigmoid. This is caused by Proctitis vincenti and the Bacillus fusiformis, leading to the strawberry lesion of the rectosigmoid, another proctitis. The leading symptom is diarrhea in these cases, often scanty bloods which are scantily blood stained. So symptom is diarrhea, maybe there is a blood staining of the stools. Stool examination shows presence of specific organism in these patients, which is Proctitis vincenti and Bacillus fusiformis. Sigmoidoscopy in these patients shows thick lesion with raised mucosa and superficial ulceration in the rectosigmoid, with blood oozes at numerous pinpoints, giving the appearance of an overripe strawberry. That's why we call this condition as a strawberry lesion of the rectosigmoid. A swab should be taken for vincentitis and fusiform organism, and bacteriological this organism, they can be seen for diagnosis. Swabs from the gums and the throat are also advisable in these patients. So this is strawberry lesion of the rectosigmoid. Another condition, rectal bilharziasis, which is caused by Schistosoma mansoni. It is endemic. This condition is endemic in many tropical and subtropical countries, and particularly in the delta of the Nile, Egypt. This is the area where this rectal bilharziasis is prevalent. So this presents in stages. In the first stage, initial part of the disease, a cutaneous lesion develops at the site where this trematode enters this parasite, because this parasite is of fresh water. This Schistosoma mansoni is a parasite of freshwater snails. So cutaneous lesions develop at the site of entrance of the cercaria. So initially in the stage 1, a cutaneous lesion develops. In the stage 2, which is characterized by pyrexia, urticaria, and a high eosinophilia, both these stages are frequently overlooked. So it is the third stage, which results from the deposition of the ova in the rectum, and it is manifested by bilharzial dysentery. So this is rectal bilharziasis caused by the Schistosoma mansoni. In this condition of proctitis, papillomas, which may be sessile or pedunculated, or they contain the ova of this trematoda, which is Schistosoma mansoni. Condition, if it is untreated, the rectum becomes festooned and the prolapse of the diseased mucous membrane is also present. Multiple fistulae in ano are prone to develop in this condition. Again, the primary treatment in this condition is also systemic, IV antibiotics. When the papillomas persist in spite of general treatment, they should be treated by local destruction. So they should be managed locally. Another variety, proctitis due to herbal enemas. This is another condition when herbal enemas, they are used to treat constipation that can result in proctitis. Again, this clinical entity is present in tropical countries, especially the Africa, where these enemas, they are used. Following an enema consisting of a concoction of ginger, pepper, and bark administered by a witch doctor, virulent proctitis occurs. Pelvic peritonitis sometimes supervenes in these patients. So these are again treated with bed rest, large doses of morphine and antibiotics, and suppositories of 5-SA aminosalicylic acid with stool soft soup. Temporary colostomy is sometimes done in these patients, resulting proctitis due to herbal enema. So this was all about the proctitis, its types, non-specific and specific, then the specific infection leading proctitis we have talked about, and their treatment. Now we come to the benign rectal tumors. The benign rectal tumors, the rectum along with the sigmoid colon is the most frequent site of polyps. And also the cancer in the gastrointestinal tract. So this is the very common, along with the sigmoid, this is the most frequent site of polyps, rectum and sigmoid colon. Adenomatous polyps of the colon and rectum have the potential to become malignant. Again, keep in mind, adenomatous is something which have to be highlighted. Adenomatous polyps of the colon and rectum have the potential to become malignant. Now, the chance of developing invasive cancer in these patients is enhanced if the polyp is more than 1 centimeter in size. So that if the size of these adenomatous polypi, it is more than 1 centimeter, the chance of developing invasive character is more. So the size is important in these cases. Removal of all the polyps is recommended to allow complete histological diagnosis and exclude carcinoma. This is best done using endoscopic biopsy or snare polypectomy techniques. If one or more rectal polyps are discovered on sigmoidoscopic examination, a colonoscopy must be performed. This is another important point you should keep in mind. So then the rectum shares the same spectrum of polyps as the colon. Polyps are described in terms of their appearance, pedunculated, whether they are pedunculated, whether they are sessile, whether they are flat, or the histological composition, whether they are tubular, villous, tubulovillous. So if we now talk about the polyps which are relevant to the rectum, there are a number of polyps, and their spectrum described in terms of their appearance or histological variety. In terms of appearance means whether they are have a pedicle whether they are sessile or maybe these polyps they are flat. Histological composition divides them into tubular variety, then villus variety, and tubulovillus. The tubular adenomas or mixed tubulovillus adenomas are the most common type of polyp in the rectum. Keep in mind, again I repeat, tubular adenomas are mixed tubulovillus adenomas are the most common type of the polyp of the rectum. They have the potential to turn malignant, particularly if the size is over 1 centimeter. If we talk about the villus adenomas, they have a characteristic frond-like appearance. They may be very large, occupying much of the circumference of the rectum. These tumors have an increased tendency to become malignant as compared to the tubular or tubulovillus. Villus adenomas, they are more prone to become malignant. Rarely these villus adenomas, they produce profuse mucus discharge from these tumors, which is rich in potassium and causes electrolyte and fluid losses. Hypokalemia leads these villus adenomas, they can cause hypokalemia. This is one point which you should keep in mind. If there is on digital examination, there is a hard area in these adenomas, and then chances are there that maybe they are malignant and they must be biopsied in those cases. Treatment of these villus adenomas, provided cancerous change has been excluded. These tumors can be removed by submucosal resection endoscopically, surgically, again through the per annum, by sleeve resection from above. Transanal endoscopic microsurgery is another technique to deal with these adenomas. Rarely the option of rectal excision is there in these cases. Then familial, the rectal adenomas, they may be part of familial adenomatous polyposis, which is an autosomal dominantly inherited condition which is characterized by multiple rectal and colonic adenomas around puberty. It is due to mutation of the adenomatous polyposis coli APC gene. As you know, genetic testing in the 75% of the families in which a mutation can identified. A colonoscopy and biopsy will confirm the diagnosis. This is a very specific condition. Familial adenomatous polyposis and rectum is involved in this case. So one of the polyps of the rectum, they may be part of the familial adenomatous polyposis. So treatment in these cases, again, total adenomatous polyposis coli, total colectomy must be performed, but regular flexible endoscopy, removal of the polyps before they develop carcinoma. So if you do total colectomy and leave the rectum behind, you have to repeat flexible endoscopic examination and keep an eye on the rectum in these cases. Restorative proctocolectomy with ileal pouch, anal anastomosis is another option in which proctocolectomy is done. And it is restorative, obviously, when we do a ileal pouch and anal anastomosis. A pan-proctocolectomy, another option, a pan-proctocolectomy with permanent ileostomy, especially when patient follow-up may be impractical. So another option in cases of adenomatous polyposis coli is pan-proctocolectomy and then permanent ileostomy. So these are the option of treatment in cases of adenomatous polyposis coli. So the other polyps relevant to the rectum is hyperplastic polyp. These are small pinkish sessile polyps about 2 to 4 millimeter in diameter, and they are frequently multiple. They are common and generally harmless. Keep in mind, I'm talking about hyperplastic polyps. They are small, pinkish, sessile polyps. Size is about 2 to 4 millimeter in diameter. They are multiple and they are common and generally harmless. Keep in mind about the hyperplastic polyps. Inflammatory pseudopolyps. Inflammatory pseudopolyps, these are basically edematous islands of mucosa. They are usually associated with colitis, but most inflammatory diseases, including tropical disease, can cause these inflammatory pseudopolyps. Even in ulcerative colitis, pseudopolyps, they are formed. They are more likely to cause radiological radiological difficulty, as the sigmoidoscopic appearance is usually associated with obvious signs of active or quiescent inflammation. So while talking about the inflammatory pseudopolyps, keep in mind they are inflammatory, and one example of this ulcerative colitis. Sigmoidoscopy in these cases will show obvious signs of inflammatory cause. So this is inflammatory pseudopolyps present in the rectum. Another variety of the rectal polyp is juvenile polyp. This is a bright red, glistening, pedunculated sphere which is called cherry tumor, which is found in infants and children. Occasionally, it persists into adult life. It can cause bleeding or pain if it prolapses during defecation. It often separates itself sometimes, but can be removed easily with forceps or snare. A solitary juvenile polyp has virtually no tendency to become malignant, but should be treated if it is causing symptom. It has a unique histological structure with large mucus-filled spaces covered by a smooth surface of thin rectal cuboidal epithelium. Again, I repeat, if somebody asks you what is the commonest cause of bleeding per rectum in infants and children, your answer should be juvenile polyp. So it's another variety of rectal polyp. It can be present in the rectum, it may be out there in the sigmoid and more proximally. So the presentation of juvenile polyp, hematomatous polyp, also called bleeding per rectum or pain when it prolapses. This is again rarely autosomal dominantly inherited syndrome. Juvenile polyposis does confer an increased risk of gastrointestinal cancers. This is a specific type of a condition, autosomal dominantly inherited juvenile polyposis, which is characterized by multiple juvenile polyps and a positive family history. 2 points. Multiple juvenile polyps and a positive family history. This is case of autosomally dominantly inherited syndrome, juvenile polyposis. So if we summarize the polyps in the rectum, they are either single or multiple. They may adenoma are the most frequent histological type, Villous adenomas may be extensive and undergo malignant change more commonly than the tubular variety. All adenomas must be removed to avoid carcinomatous change, and because adenoma to carcinoma change is a definite pattern for invasive cancers of the rectum. All patients must undergo endocolonoscopy to determine whether further polyps are present more proximally. Most polyps can be removed by endoscopic technique, but sometimes major surgery is required in these patients. Now, there are two more conditions we are going to talk about is endometrioma, another benign tumor of the rectum. Endometrioma is a rare and maybe misdiagnosed as carcinoma. It's a part of endometriosis in the female. It produces either a constricting lesion of the rectosigmoid or a tumor invading the rectum from the rectovaginal septum. The later variety gives rise to a very tender submucous elevation of the rectal wall, that is the rectovaginal, from when it arises from the invading from the rectovaginal septum. Endometrioma occurs usually between 20 and 40 years of age in cases of female. Dysmenorrhea and the rectal bleeding, particularly which is coinciding with the menstrual cycle, are the main symptoms of endometrioma. Sigmoidoscopy in these patients shows a stricture at the rectosigmoid junction with the mucous membrane which is intact, and then also the history which is very important in this patient. Treatment is hormonal. It is hormonal therapy, which is the first line of therapy. Total abdominal hysterectomy and bilateral salpingo-oophorectomy and even bowel resection may be required in these patients. Another benign tumor of the rectum we are going to talk about is the hemangioma. Hemangioma of the rectum, which is uncommon cause of serious bleeding, hemorrhage from the rectum. When localized in the lower part of the rectum or anal canal, a hemangioma can be excised easily. When the lesion is diffuse or it is lying in the upper part of the rectum, the symptoms simulate ulcerative colitis and the diagnosis becomes often missed for a long period, or it is mistakenly thought to be a carcinoma when hemangioma is proximal in the proximal part of the rectum. So what is the treatment? Selective angiography and embolization, which is required, which also gives support for diagnosis and the treatment. Excision of the rectum is rarely required in these patients. So this is hemangioma of the rectum presenting with the bleeding, and one condition we have to give suspicion of malignancy. Gastrointestinal stomal tumor, they are less maybe smooth muscle tumors of the rectum which are rare. If the mitotic rate is high on histological examination, and if there is variation in nuclear membrane size and shape, hyperchromasia and frequent bizarre cells, these tumors are likely to metastasize. So this is basically GIST tumors of the rectum we are talking about. GIST treatment should, whenever possible, by the radical excision. So this is another tumor of the rectum, gastrointestinal stomal tumor, GIST tumor. So this is all about the benign tumors of the rectum. If you have any questions, you can ask me on your WhatsApp group. I'll respond on that group. Thank you.